I forgot my little lav mic, so I'm going to be kind of like grounded over here today. Hopefully I won't wander away too far. So we've got Sunday, we'll have Sunday into Monday night. I will reset it so that the quiz is open Sunday noon until Monday at midnight. So it'll be chapters 4, 5, 6. So we'll wrap up 6 today. Bear in mind, I am expecting you to read the chapter, take notes on the chapter, right? I am not covering all the chapter components. I don't have enough time to cover everything and give you some supplemental information. So everything that we cover in class as well as in the chapter is fair game. Okay. And then you have the homeworks due as well. I've received your health leader papers, and I will get to them as soon as I can. I've got a lot of other stuff cooking right now, so hopefully by early next week I'll have those too. All right, so we're going to wrap up 6 today. Spent most of the class last time talking about fee-for-service and explaining to you how physicians really bill. That's a useful thing to understand as you go out into the world. So if a physician did a service on you, you're going to get, if you're in a hospital setting, so a facility setting, you are going to get multiple bills. You'll get one based on all that stuff we did, the calculations we did in class, the RVU style bill. You will get a bill from the hospital for what's called a facility charge. Sorry, my mask is itchy today. You'll get a charge from the hospital. It's called a facility charge. That's meant to basically cover all the costs of running the hospital. So it's the nurses that took care of you. It's the radiology tech that took the image of you. It's the housekeeper that cleaned your room, yada, yada, yada. That's the facility charge. And that applies whether you're inpatient or outpatient. And I had a question about urgent care, I think last time. And so an urgent care facility, I kind of hesitated because the answer is it depends. And it depends on whether the urgent care facility is owned by and I'm not going to ask you this, but since it got asked, I will try to answer it. It depends on whether the urgent care facility is owned by a hospital or not, and whether it is considered part of the hospital's campus or not. So for example, Wentworth Douglas owns an urgent care facility in Lee Circle. And if you're not familiar with the geography, that's a good 10 miles away, right, from where Wentworth Douglas is, thereabouts. It's a good long distance. If you go to that urgent care facility in Lee Circle, it is not considered part of the Wentworth Douglas. It's owned by Wentworth Douglas, but it's not part of the Wentworth Douglas system, and so you won't get a facility charge going there. If they had an urgent care facility on, say, if you're familiar with Wentworth Douglas campus, like on their campus, let's say maybe either in the hospital itself, for sure, you're going to get a facility charge. So there are emergency departments that have created kind of like 2 tracks. You come into the ED and you say, I have a bad cold. They're like, all right, you're urgent care. So you've now tracked over to urgent care instead of plugging up the ED. And they may have the urgent care staffed by nurses or whatever. If there's an ED doctor, they might have you are going to get a facility charge because you are getting seen in the hospital. If they put up an urgent care facility within a certain area of the hospital, so within a certain distance of the hospital, this is where it gets kind of technical, it could still be considered part of the hospital. The plus side for the hospital is they get to bill for that. They get to bill extra. They get to bill you this facility charge in addition to the doctor's charges. The downside is it's part of the hospital, so then it gets covered by Joint Commission and some other stuff. So there's kind of pluses and minuses to that. Joint Commission is an organization that comes out and certifies that the hospital is providing care in a safe manner. And you have to get that certification if you take Medicare. So you have to either go with the Joint Commission. There's a couple of other choices. I think we're going to talk more about that a little later. So I don't want to spend more time on it. But anyway, so the answer to the urgent care question was, it depends. Most likely not, but it is possible if you are going to an urgent care that is owned by a hospital and the actual building is, and the actual or clinic is either inside the hospital or physically close enough to the hospital to be counted as part of the hospital. So there's a lot of complexity in healthcare, if you haven't already noticed, right? About this stuff, and a lot of goofy rules. So I started to talk last time about alternative payment models. So in our chapter about the history of healthcare, we had pre-industrial, industrial, corporatization, and then health reform was the last stage that our book talks about. So alternative payment models are part of that health reform process. What we realized was every time the government comes up with, and or insurers come up with a mechanism that they think is going to control costs, the really, really smart people who work in healthcare figure out ways around those mechanisms to control costs because they want to make more money, right? And so you keep this process, of continuous process of gaming that is going on, because going all the way back to that first class we had where I showed you the picture of the fish and the picture of the clock, right? The more you think that the economy works like a clock, the more you're going to get gamed. Every time you think you're going to tweak something, there's a whole bunch of fish that are swimming around because you think you're working with a clock, but you're actually working with a school of fish, right? And the fish are going to go, oh, not that way. I'm going to go this way so that I can get to the money, right? And again, it is wrong-headed to look at that as evil. Instead, you should just look at that as that's reality. You don't get a choice to not deal with that. Human beings are always going to seek out what's best for them, right? And some of what's best for them, if they work in healthcare, is they get to take care of people, right? They're motivated, at least to some degree. I know very few healthcare people who don't genuinely care about other human beings. They're out there, but most people that work in healthcare are driven by a sense of mission, but they also like money, right? And so when they're given a choice between making the money and not making the money, they're going to make the money, right? And take care of the people. So keep that in your head when you think about these things. So alternative payment methods is yet the latest kind of iteration where the government is trying to figure out a way. And I say the government, but it's also insurance companies. And insurance companies tend to follow the lead of the government because Medicare and Medicaid are such a significant factor in the healthcare industry and they're the biggest payer in the healthcare industry. So they shape the market profoundly. So whatever Medicare does, industry, private health insurers tend to follow. So APMs came out of the ACA. So we passed the ACA back in 12. It started to take effect in 14. And alternative payment methods are there. Now, capitation way predated the ACA. You can track capitation back, depending on how you want to define it, back to the 1800s, where we had this thing called lodge practices. So if you're ever driving down the street and you see one of, like you're driving down 108 from Durham up to Dover, on your right, you'll see the Loyal Elks Lodge, or if you're in, or you might see some of these other like old clubs that are, I've never been in. I've been in them, but I'm not a member of it. So in the pre-industrial age, towards the beginning of the industrial age, people were members of a lot of these kinds of clubs. And I'm not going to try not to spend too much time talking about this, but it's kind of cool. So you would be a member of like a fraternal or a sorority kind of organization, not a sorority like a college sorority, but a sorority like women get together, men get together, right? And it was a community organization. And, you might get together and it was kind of a community club. And one of the things that the community club might provide was called a lodge practice. So a lodge practice would be, you're a member of the Elks, for example, right? The Dover Elks Lodge 103 or whatever. And the lodge, so this predates health insurance, the lodge might have a vote and say, hey, we're going to hire a doctor to take care of all the members of the lodge. And the doctor would agree to provide care to all the members of the lodge for a fixed fee. And that was an arrangement. That's very much a predecessor of this idea of capitation. Now, capitation, so the idea here is capitation is a per capita fee. Capita meaning head, right? So it's a per head fee. So the provider gets a fixed fee and then provides, kind of in the pure sense of capitation, provides all of the care for the patient. So fast forwarding into the World War II era, Kaiser Permanente, I talked a little about this last time. Kaiser Permanente was a, I want to say it was Kaiser was a shipbuilder in California, and realized, he was having trouble hiring employees because the demand for employees, with everybody being called off to war, right? Finding employees to work in manufacturing to support the war effort was hard. And so he started offering, and it grew out of this employment arrangement, established Kaiser Permanente. I'm getting the Kaiser system is the hospitals, and the Permanente system is the doctor's practices, but they're kind of one large organization. And it basically became a capitated arrangement. So it kind of grew out of this, originally out of an employment arrangement with one company, and then it became its own thing. So you pay Kaiser Permanente a fixed fee, and then they provide all of your care. And they have their own doctors, they employ their own doctors, they own hospitals. And so you get care from the Kaiser system. And if they can't provide the care, then they have to pay for you to get the specialty care outside of their network. So that is capitation. It's kind of the purest form of alternative payment methods. So what's beautiful about that is it changes the incentives. So last time we talked about fee for service, right? Fee for service focuses on the inputs. So you're paying for inputs to your care, right? You pay for a scan, you pay for a therapy, you pay for a doctor's visit, you pay for a surgery. You're not paying to be healthy. You're not paying to be better, right? What you're paying for are the procedures and things being done to you. And the people in the system are rewarded to do more things. So the incentive then is to churn and do more things. Under capitation, right? So the reward to the people in the industry under fee for service is do more and you'll get more money, whether the patient really needs it or not. And so it's really up to the doctors or the provider's ethics to not say, I'm going to do this extra thing, right? When it's on the bubble between it's medically necessary, it's not medically necessary. If I'm under fee for service and I'm on the bubble between, well, maybe I could do it or maybe I won't do it, is I'm definitely going to do it because I'm going to make more money if I do it, right? But on the other hand, under capitation, right? I pay you're my provider, and you agree to take on my healthcare needs. I'm going to pay you a fixed dollar amount, whether you see me never or whether you see me every day for the next year. I'm going to pay you, let's say, $1,000 a month as a fixed fee. UNH pays a little more than that, or about that. But so for my family of three, I have the UNH plan. My wife is not covered by it because my wife and I have TRICARE insurance from when I was in the Army. So as an Army retiree, one of the benefits of being an Army retiree is I get healthcare for life from the military health system. And the insurance company, you should have read about this by now, the insurance plan that's provided by the military health system is called TRICARE. And so I have TRICARE for the rest of my life. When I turn 65, I have to pay for Medicare, and then TRICARE becomes like a supplemental insurer for me. So basically, I have a right to get healthcare from the military health system for the rest of my life. The only reason I'm currently taking UNH health insurance is because my kids, my oldest kid is aged out completely. She's now 20. She's now 26, so she no longer qualifies to get care under my plan. But I have a 22-year-old and a 24-year-old who do qualify. And when you turn 23 under TRICARE, you have to start paying your dependent, once they turn 23, no longer gets TRICARE for free. You have to now pay a fairly significant fee. And so it worked out that it was actually cheaper for me to buy the UNH plan to cover my 24-year-old, and my 22-year-old gets to go on as well. And then I get it, even though I don't need it. It was actually cheap, just because it's part of my health benefit, because it's part of my benefit package. So I had not been getting that in the past. And one of the things that UNH did was, because I declined health insurance, they actually paid me, I don't know, like $50 every period or something like that. It's a paltry amount of money. So which, I will take, because I will take $50 over $0 any day of the week, right? But it wasn't a lot of money. Now that I started taking the health insurance benefit, that is required to be reported on your W-2, and it says how much your employer pays for your health insurance benefit. Last year, UNH paid $17,000 for my health insurance benefit, which covers me and my 2 kids, right, that are covered by it. It's a lot of money. So UNH is basically, it's not a capitated arrangement, but you could imagine now 17,000 divided by 3 is, 6,000-ish. So $500. So if you were to take that money and buy a capitated plan, the fixed fee, the per member per month payment would be $500, let's say, per month for myself and my family. And then the provider who's taking that capitated rate would be required to provide all of our care, from basic primary care to emergency care to any care that I need. So that's the pure capitation. The lovely thing about capitation is now you shift the motivation of the providers from I want to do more so I can make more money, to I'm getting as much money as I'm going to get. So now my incentive is to do what? I want to prevent you from coming in. Well, I can't literally lock the doors and keep you out, because nobody will buy, fool me once. I'll buy your insurance once, and if you lock the hospital doors, I'm not buying it next month, right? So they want to make you happy, so that you want to keep buying the insurance from them. But what their incentive now is to manage your care so that it costs less than $500 a month. So what are they going to focus on? Wellness, right? They're going to bring you in and be like, hey, you getting your exercise? You know what's really great? Exercise is walking. You should walk. Oh, you don't like walking? How about swimming? Let's try swimming. Because exercise is like the best medicine for everything, right? Less cancer, less depression, right? Less blah, 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 blah. So if you have, behavioral health issues, you need to get exercise, right? If you've got health issues of any sort, you need to get exercise. It's just like the panacea for everything. It won't keep you from dying, because we're all going to die. But it's like, at the margin, the best thing you can do is get exercise. Good sleep, good exercise, good diet. Those are like the 3, if there's a silver bullet of medicine, it's those 3 things combined. You're still going to die, but you'll live healthier, longer, happier if you get those 3 things while you're on this earth. So under capitation, you are strongly, the incentives reverse for providers, and they're now incentivized to do less interventions. And so they're going to be a little more, when they're on the bubble between could I do this scan or not do the scan, they're going to prefer not to do the scan, right? And they're more likely to be like, let's wait and see. Okay, you got knee pain. We could do the MRI right now, but you know what? Most knee pain just goes away on its own after 6 or 8 weeks. So let's just see what happens in 6 weeks. And if you're still in pain, then we'll go, oh, well, let's try some exercises. Let's go to PT first, rather than going to see the orthopedic surgeon, because PT is going to be a couple $100 for 6 weeks of treatment, and going to see an orthopedic surgeon is going to be $1,000 just to walk in the door. So it's, so they start making they make better decisions. Capitation on average, encourages making better decisions that are more focused on your outcomes, right, rather than the inputs. They want to keep you healthy so you don't come in as much and don't use as much. So the incentive now is, instead of paying for your illnesses and treating your individual illnesses, it is now incentivized to actually take care of you and your health outcomes. So that's what's nice about capitation. It is not common. it is probably, it is, like I said last time, some 95% of healthcare is still delivered under a fee-for-service model of some shape or form. But most people who get Kaiser like it. Kaiser's a really good organization. They do a good job. And most people like that care. So another alternative that is now being pushed is called bundled payments. Bundled payments is an idea, and it's a clever idea, and it makes a whole lot of sense. And it's kind of like, why wasn't this thought of before? So like you get seen, you have knee pain, and it turns out, yep, you really have torn your whatever ACL or something, and you really do need surgery, or you really do need a hip. You're 80, you fell, you broke your hip, you're going to really need hip replacement surgery. Okay, now under fee for service, right? We charge you for each visit. You can't, we charge you for the visit to see the orthopedic surgeon. We charge you, when you come in, we charge you for the pre-op evaluation. We charge you for the surgery. There'd be a separate bill for the anesthesia. There'd be a separate bill from the hospital for the facility charges. Then you'd pay a separate bill for physical therapy, maybe a couple of days in a rehab facility, right? All that stuff would be, you'd be getting 47 bills from all over, right? You'd be getting the doctor bill, and you get the, then you get the anesthesia, and you're like, who the hell is this person? Oh, who's the anesthesiologist? Okay, I've got that bill now, right? Got lab bills, got X-ray bills, right? All these different things are coming in. Well, instead, what we say is hip replacement surgery. We're pretty confident we know what's going to go into that. It's going to have pre-op. It's going to have a bunch of X-rays. It's going to have MRI. It's going to have, we're going to do the actual surgery. The surgery is going to include putting in a new artificial hip. That's a cost, right? It's going to have, we're going to need to use the OR. You're going to spend the night in the hospital. Then you're going to need 2 or 3 days in a nursing home to do rehab. And then you're going to need maybe some home care, because we're going to try to get you out of we're going to try to keep moving you along as fast as possible. We're going to move you from the hospital, which is the most expensive place to recover, to a nursing home, which is less expensive. And then we're going to boot you out of the nursing home as fast as possible, because that's expensive, and put you at home and send a home health aide to help you with your rehab at home. Well, we know all these things are going to happen. So let's just draw a big circle around them and put one price tag on it. And then everybody who's playing agrees to be part of a team that's providing, the hip replacement surgery as kind of a bundle of services. So that's the idea. Is a bundle refers to a bundle of services that are being done for a fixed price. And so it's similar to capitation, right? The bundle, the person who is organizing the bundle, people participating, agree to accept one big payment from the insurance company, and then they all agree to divvy up the money amongst themselves based on their contributions to the care. So instead of the insurance company dealing with 7 or 8 different providers of different services, they just deal with the bundle team as a single unit. And then the bundle team works together to say, all right, team, we're getting $50,000 for Mrs. Smith's hip replacement. How do we, and we know if we can do it for less than 50,000, then we're going to make a profit. So where can we streamline? Where can we do things better? Well, like the example I just used, well, instead of letting Mrs. Smith stay in the hospital for 3 days, let's have her for 24 hours in the hospital, then push her down to a nursing home, which is cheaper, because that saves us money, because we're on the hook. We're getting $50,000. So if Mrs. Smith spends 3 days in the hospital, that's going to eat up a lot of our profits. So instead, we're going to push her to a lower level of care. Maybe we'll send her directly home from the hospital after 24 hours, directly home, and have a home health aide at her house when she rolls in, ready to help, right? Or a home health nurse ready to help. And then the day after, we're going to have the home health agency is going to provide physical therapists. It's going to show up, right at 7 a.m. the next day to get her up and walking, because that's the goal. I did an interview with a Kaiser Permanente leader. He was the chief operating officer for Southern California, all of Southern California. His name is Dr. Nirav Shah. And he was saying, what we're shooting for with Kaiser is to turn hip replacement into a same day surgery, which means you come in, you get your hip replaced in the morning, and by night you're home in your bed, right? Or maybe not your bed. We've put a hospital bed in your bedroom or in your living room or wherever, right? And when you go by nighttime, when you show up at your house, there's a nurse waiting to get you settled in. And first thing the next morning, there's a physical therapist. So I'm not making this stuff. This is really happening. And the goal there is, again, Shaw is part of that, the capitated model, but the same, but kind of these bundled payments kind of chunk out pieces. So it's not true capitation, but it is a fixed payment. So it's the same kind of incentive. So now for example, if something goes wrong in the surgery and you have to be readmitted, the insurance company doesn't pay for a second surgery. Under standard fee for service, if something goes wrong with the surgery and you get readmitted, the doctor now gets a second payment to fix the thing that went wrong the first time. Under bundled payment, that's all on them. So what happens? Well, now we're super concerned. The whole team is like, hey, doc, don't screw up, right? Because if you have to do a second surgery, that's money off of us, right? So they all start thinking like, how do we prevent infection? How do we, make sure that everything goes right the first time? And so what that does is it incentivizes everybody to work together to really focus on a positive outcome rather than figuring out how many services can I do to bill you. Does that make sense? So these are all good things. And the bundles are not just orthopedics, so that's probably the simplest version. They also are starting to bundle things like cancer care and a bunch of other services. All right. So I want to keep talking here about so there are other alternative payment mechanisms. The big ones I want to talk about today are shared savings and shared risk. So Medicare, under ACA, Medicare is required to create this thing called Medicare Share Savings Program, Medicare Shared Savings Program, MSSP, right? And the shared savings program, there's two kinds of shared savings. One is called shared savings. And this is upside risk only. And this is part of what's called risk contracting. So most hospitals are engaged now, even if they are primarily fee for service, they are engaged, most of their contracts. Yes, ma'am. Oh, crap. Thank you. There we go. How's that? Okay. So, oh, well, that should be recording. Yeah. Okay. So most contracts now have a risk sharing component, and so it's called risk contracting. So, like I said, Medicare leads the way because it's the biggest payer in the country, but Cigna and Blue Cross and all those companies are now inserting shared savings or some variation on risk contracting into their contracts. So what is this? Well, first, what we do is we decide on a reliant population. So for Medicare, you have to calculate it or you have to estimate it for private insurance. You just have a contract. You know who's covered. You have a contract with a hospital. So Cigna would have contracts with Wentworth Douglas, for example. Cigna is the UNH provider. So they have a contract with Wentworth Douglas, and part of the contract will be all those PPS rates we talked about last time, the prospective payment rates, but then they're also going to insert here a shared savings contract. And so so under Medicare, what we do is we decide who is the reliant population for a particular hospital. So if Wentworth Douglas signs up to be part of the Medicare shared savings program, and Wentworth Douglas would do this, getting a little ahead of myself. Wentworth Douglas would do this with its providers, and it would agree to engage in this contract. So let's kind of pause for a second. So first, what Medicare says is, well, who is a regular user of your services? And what they do is they say, okay, how many people are getting their primary care from you? So the first screen is, does Mrs. Smith get her primary care through the Wentworth Douglas health system? And so they have providers there. So if they say yes, then they say, okay, Mrs. Smith is going to be included in her care is going to be included in your target. And so you'll have, Mrs. Smith will be part of your reliant population. So the way they figure that out is, where do you get your primary care? So this is the Medicare version of this. So then what they say is, what they look at is the prior year spend for the reliant population. So how much did the reliant population spend in 2021, right? And that becomes their benchmark. So for Wentworth Douglas, for example. So let's say that the answer is all of the people who were judged to be reliant on Wentworth Douglas, so they got their primary care through Wentworth Douglas, they spent a total of $100 million on care last year. That's probably well below the actual, but I'm just using simple numbers, because Wentworth Douglas by itself brings in, just the hospital brings in about 400 million in revenue a year. So this would be the Medicare reliant population, and even that's too low. So I mean, reality would probably be more like 300 million for the Medicare population, but I'm just using simple numbers to do this math. Okay, so let's say that the people who are judged to be medically reliant on the Wentworth Douglas system spent $100 million last year. What Medicare then says to Wentworth Douglas is that if that population spends less money next year than it did this year, we'll let you share in the savings. And that shared savings rate ranges from 40 to 100%. So shared savings rate is somewhere between 40 and 100%. So let's say their benchmark is 100 million. So in 2022, what Medicare says to Wentworth Douglas is, if the reliant population spends less than 100 million, you get to share, let's say 50%. So let's imagine for this case, it's 50%. So if Wentworth Douglas then is given information about all of these patients. Now here's a thing you have to keep in mind. Mrs. Smith, who's representing the reliant population, may also, so Wentworth Douglas is a community hospital. Mrs. Smith has some sort of complex, let's say, God bless her, has some sort of complex cancer, and it's above what can be cared for at Wentworth Douglas. So last year she started getting her care at MGH. Well, part of that $100 million is money that Medicare paid to MGH, not to Wentworth Douglas. So this $100 million that's spent on the reliant population is not just coming from the facility that is agreeing to be responsible for this medical spend. So one of the things Wentworth Douglas can try to do, a couple of things Wentworth Douglas is going to try to do. One is they're going to try to, they know if they can, if in 2022, the total medical spend is less than 100 million, they're going to get to keep half of that. So let's say that in 2022, the medical spend is 90 million on the Reliant population. That means that they have 100 minus 90, 10 million in savings. They get to keep 0.5 times 10, $5 million. Now, Mrs. Smith is reliant on Wentworth Douglas, so that means that probably she's getting some of her care from Wentworth Douglas. So they can directly influence her care when she's at Wentworth Douglas. But they can now take an interest in her overall well-being. They are now incentivized to look into her overall well-being, and she's just a representative of all of the Reliant population, right? So there's Mrs. Jones and Mr. Jones and Mr. Williams and so forth, who are all considered Reliant. And so Wentworth Douglas gets access to all the Medicare bills for all the Reliant population, right? And so there's a shop inside of Wentworth Douglas, a group of people in Wentworth Douglas that are screening through all of the bills that get processed by Medicare on behalf of the Reliant population. And what they're trying to figure out is, all right, is this normal, right? Is there something we could do for Mrs. Smith that could reduce the amount of money she's spending? If yes, then let's intervene. Let's send a, let's get her lined up with a care manager, which would be a nurse who specializes in looking at how an individual is being cared for, right? What are the, if she's got cancer, but she also has diabetes and a bunch of other things. So a care manager, a nurse care manager, will help kind of manage the individual's overall care. And that's really useful because Mrs. Smith might be 75, 80 years old, doesn't understand all of the things that are being done to her or why. She's just doing them because she's being told to do them. And again, if we're in a fee-for-service world, right, the doctors and the providers, the various providers, are always going to tilt when it's on the bubble, meaning it could go this way or that way, right? They're always going to tilt towards doing more. Well, a care manager can kind of step in and counsel Mrs. Smith to say, actually, you really, why don't we wait on the MRI? You don't need it today. If you still have pain, in 3 weeks, then we'll look at getting the MRI. So the organization now has an incentive to try to reduce the overall medical spend. And bear in mind, the overall medical spend is not just the care provided in the Wentworth Douglas system. It's also specialty care outside of the Wentworth Douglas system. Okay. Now, what happens under shared savings if the medical spend instead in 2022 is 110 million? Well, that's 100 benchmark minus 110 is minus 10 million. Well, nothing happens under shared savings because, sorry, yes. Sorry? There's a box. Okay, yep, thank you. My last class just got done processing. All right. So in this case, because it's a shared savings program only, they only have upside risk, right? They can't lose. So if the spend is 110 million instead of 100 million, they wind up spending $10 million more. They aren't out anything. They don't lose anything, but they don't get a bonus. So this is called upside risk only, right? Shared savings is upside risk only. So this is a simplified version. The next variation on this is two-sided. So this, they wind up getting nothing, right? Because the number went over, they wind up getting nothing. So two-sided risk contracts have both upside and downside risk. So it operates the same idea, except, so if they did well, if the benchmark was 100 and they brought it in at 90, they'd share half, under this simple example, they'd share half of the $10 million in savings. But under two-sided risk contracting, if the money comes in at 110, well, now they share in the loss as well. So they will lose, they will have, typically the way this works with shared savings is the insurer holds back a certain amount of money, and they don't pay it until the end, and then you either get all the money or you get a bonus, or you get your bonus. In this case, they would have withheld the money in advance, and they just wouldn't give it to you, so they'd hold that $5 million back. So under shared savings, under upside only, you win if you reduce the spend, but you don't lose anything if you fail to if the spend comes in higher. Under two-sided, you're on risk for both. You can win and you can lose. Under shared savings, upside only, you can only win, right? So the direction has been, we've been doing this now for 7 years or so, and the baby steps have been start with the upside only, get people used to it, thinking about it, setting up their systems, because this is not a thing that hospitals cared about prior to the ACA. They didn't think about total spend of a reliant population, right? All they focused on was, how can I get you in here to spend, to get more care so I can collect more money, so I can make more revenue. This is an alternative payment method where we're trying to incentivize the providers to save money. So Wentworth Douglas can reduce that medical spend, right, by reducing the utilization of other providers outside of their system. That's one way they can reduce the medical spend. I did an interview with the COO of Leahy. I don't know if any of you did talk to or read or listened to Patrick. He's now up at Dartmouth Hitchcock as the COO. But I talked with Patrick, and he talked about how Leahy is part of a ACO, an accountable care organization. And this is a network of providers that that engage in risk contracting. Now, Leahy is big enough, is part of Leahy, Beth Israel, thank you. So it's Leahy, Beth Israel. So it's a big system now. They've got a whole bunch of hospitals. So they're pretty complex. So they can be an ACO all by themselves, which they are. But you can also have, we had an ACO up here in the southeast of New Hampshire that consisted of Exeter, Wentworth, Concord, and I think two other hospitals. So they joined together to kind of cover the southeast of New Hampshire. And then they built infrastructure that sat at Concord Hospital that did all the analytics and figured out, okay, Mrs. Smith is spending a lot of money. Let's look into Mrs. Smith, kind of thing. So ACOs are networks of providers, such as, maybe a group of hospitals and some physician practices and some nursing homes and some surgery centers all come together to form an ACO. And then that ACO takes responsibility for the medical spend for this reliant population. And they can either be all part of the same network. So the Leahy example is all of the participants in the Leahy ACO were part of the Leahy system, or they can be independent, which is, I think they call themselves Granite something. And it was 5 or 6 New Hampshire hospitals that were not part of a formal network, right? But they all kind of rode together with the shared savings or the shared losses. Okay? So ACOs you're going to hear a lot about. All right. Let me jump back. Let's talk about insurance for a minute now. I'll go back to insurance. Some basics of insurance. All right. Let's say, how do insurance rates get set? Well, they're set by actuaries, and they do some calculations that look something like this. This is a super simplified version. So Archibald is a big skier. He knows he has a 1 in 100 chance of breaking his leg. The cost of the care would be $30,000 if he breaks his leg. You know, all the care together, right? So it'd be $30,000 if he breaks his leg. So without insurance, he's got 2 possible outcomes. 99% chance he's going to have to spend nothing, right? He'll go skiing all season and be fine. But there's a 1% chance that he'll get into a bad accident and break his leg and have to spend $30,000. And since he only makes $50,000 a year, having to pay $30,000 would be pretty devastating. He might lose his home, right? He might have to sell his car, so forth. So this would be what we called, back when we were talking about insurance, a catastrophic loss, right? Now, if he was Bill Gates and he made, $47 billion an hour, he wouldn't care about $30,000. He wouldn't need to necessarily to get insurance, right? So if this was $30, right? If the cost of getting his leg repaired was $30, Archibald wouldn't need to buy health insurance. He'd just pay it out of pocket. So, so he's going to want to buy insurance to kind of try to smooth this spending out. So he decides to join a pool of skiers who all have the same chance of getting hurt and the same potential costs. So what is the, so how do we figure this out? How much is an insurance? So they get together as a pool and they contract with an insurance company. So let's say that there's 100 of them, and they form this pool, and they know that chances are of the 100 of them, because there's a 1 in 100 chance that one of them is going to get hurt. Better yet, if there's 1,000 of them, right, there's a 1 in 100 chance that 10 of them will get hurt. Because in 1 in 100, you could imagine rolling the dice, right, over and over, and it's possible you could roll a 100-sided die 100 times and never get a 1, right, or 100, or whichever one you want to say is the bad number, right? So it's possible you could roll a die 100 times and not get to come up with the one that says, okay, you lose, you have to pay $30,000. But if you jump that up to 10,000, if you're going to roll the dice 10,000 times, you're pretty sure you're going to get, 100. You're going to probably hit one, roughly 100 times. If you bump it up to 100,000, right, it becomes more and more certain that you will hit the loss, the projected loss, right, the proportional loss. That's called the rule of large numbers. So the bigger the pool is, the more certain we are about that 1 in 100 loss happening, or that 1 in 1,000 loss, or whatever. We still don't know who in the pool is going to be the unlucky person. If we did, then that's not really insurance anymore, right? Insurance requires that we don't know who's going to be the unlucky person. And so because we're in a group, let's say all of us are skiing with Archibald, and we all know that one of us, there's a high probability, there's a 1 in 100 chance that one of us is going to get hurt, then we're likely to be willing to pay for insurance because $30,000 is a lot of money to any of us in this room. It's a lot of money to me. I'd insure against that. Right? I wouldn't necessarily buy insurance against a $500 loss or a $1,000 loss, right? But I certainly would against a $30,000 loss. It's a lot of money. So how do we calculate this? I'm just going to jot this down. So he's got a 1 in 100 chance of a $30,000 loss, and then MLR of 85. So how do we do this calculation? Well, when we do this kind of probabilities, we've got hurt and not hurt. Right? He's got and the probability is hurt is 1 out of 100, and the probability of not hurt is 99 out of 100. The cost, or the medical loss, right, if hurt is 30,000. The probability, the cost if not hurt is 0. So then we cross multiply and we get P times C, and we get 1/100th of 30,000 is 300, and 99 hundredths of 0 is 0. So the expected loss, so EL is expected loss is 300. So ideally, so Archibald actually expects, statistically, the minute Archibald steps onto the slopes, he's lost $300, right? Statistically speaking. But we don't live in a world of statistics. We live in a world where either you fall down or you don't, right? So statistically speaking, he's lost $300 the day he straps on his boots and gets onto the building. But we don't live in that. That's not the real world. That's statistics world. We don't live in statistics world. We live in real world where we either lose nothing or we lose $30,000. But that's how much he expects to lose statistically. So if he was to ski for 100 years, he would eventually lose that $30,000. Averaged over 100 years, right? It would be $300 a year. You can think about it that way. So, but because he lives in a world where he's either going to be fine or he's going to have a catastrophic loss, he wants to buy insurance. Well, the insurance company, looking across 100 people, says, we're going to lose $30,000. We project, if we insure 100 people, we project we're going to lose $30,000. We could charge everybody $300. 100 people times $300 per person is $30,000, right? That would be fair, wouldn't it? Yes, and in fact, that's called a fair game. But we're not going, so that's actually called a fair game. Where the expected loss is equal to the price, where expected loss is equal to the price, right? So this would be a fair game if the insurance company charged Archibald $300. Well, here's the problem. The insurance company is a company. It has to have people that handle the claims. It has to hire, somebody to process the claim when somebody gets hurt. It has to have somebody to make the estimate. All right, it's a 1 in 100 chance. It'll be $30,000. So we should do blah, 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 right? So these people actually expect to be paid. Surprise, like if you work for an insurance company, you expect to be paid. So an insurance company can't charge you exactly a fair share of the expected losses. They have to cover their own expenses, right? So the insurance company has administrative costs, such as, hiring actuaries, paying bills, all that kind of stuff, and then profit, right? Because nobody's going to set up a company that doesn't make any money, unless it's a not-for-profit, in which case it still needs to need to make a profit so that it can reinvest in its stuff. But let's just say every company needs to make a profit, whether they're not-for-profit or not, right? So when we calculate an appropriate premium, we have to calculate in administrative cost and the profit. So what the ACA said for healthcare companies is you can have a medical loss ratio of 85% if you are a large company, or 80% if you are a small company. So what that means is, for a large company, that means that they have to spend 85% of their premium on the medical losses, and they can keep 15% of the premium for themselves to be their admin costs and their profits. So if I have a premium, right? Premium is the amount you're paying for the insurance. So a premium, right? And 85% of that premium has to equal my medical loss, my loss. So we know that the expected loss per person. So I'm now looking at a premium for one individual. So the medical loss per person is going to be 300. So 0.85 times the premium has to equal 300, because the expected medical loss is 300, right? So 85% of whatever I charge for a premium has to equal 300. So that premium, the most I can charge would be, I'm just going to divide through by 0.85, right? That cancels here. And so my premium is equal to 300 divided by 0.85, or $353. So if Archibald wants to buy this health insurance to cover his expected losses, he can expect to pay $353. $300 will cover his actual statistical medical loss, and then $53 will go to the insurance company to cover their administrative expenses and their profit. Okay. So the higher your expected medical loss is, of course, the higher your premiums are going to be. So if you start incorporating into that things like, okay, in addition to covering if you fall down, we're going to cover an annual colonoscopy, and that's going to cost $5,000, and you're going to get that whether you get it or not. We're just going to tag that $5,000 onto the $300. So now you've got $5,300 divided by 0.85, which is going to be a lot more money. But that's what the insurance we actually have, right? So I talked about pure insurance versus prepaid expenses. So the pure insurance, what we just described here, is pure insurance. Archibald doesn't know if he's going to fall down and go boom or not, but statistically speaking, he will, and the cost will be $300 to him. Again, Archibald doesn't live in statistics world. He lives in the real world, where he either falls down and goes boom, or he doesn't. But he doesn't want to take that chance. So he gets together with a pool of other people who have similar likelihoods of getting hurt, and they all agree together to create a plan where the insurance company then collects premiums from them and then charges them some additional costs on top of covering the actual losses. So the more expensive the care is that you're expecting to get, and the more likely it is that you're going to get, that's the other thing you could think about, is as I increase the probability of having to pay out, I'm going to increase the expected loss, right? And if I make that payout 100% likely because it's an annual physical and that's now covered by the insurance, or it's birth control and it's now covered by the insurance, or whatever, you take your pick, that just gets stacked on top, and then it just gets more and more expensive. So you're paying a 15% premium for stuff that is completely expected. All right. So there's another example in here for you to work through to practice that. I'm not going to do it. That was this one. You can try it, and I've got the solution. You can look at that. So they talk about payment. So here's a bunch of different. This is something that I found really fascinating when I learned about it. I think you should too. I can stay with it. So these are examples from some website that captures how much different costs are in the same market. So these are, it's called New Choice Health. So you can go and you can look at it. And so in the same market, getting an MRI costs anywhere between $400 and $5,700. Getting a brain MRI between $1,500 and $8,400 and so forth. So by choosing it, by shopping around, you can dramatically decrease your cost. But if you only have to pay, say, a copay of $50, then you're relatively indifferent between getting the MRI for $400 or $5,700. In fact, if the place that gives the MRI for $5,700 is really nice, and the people are really nice, and maybe they give you a foot massage while you're in the MRI or whatever, or they do aromatherapy or something, and then the other place, they just, tell you, all right, go lay down, shut up, don't talk while we're doing this, so, but they only charge you $400. Well, if you're going to pay $50 regardless, you're clearly going to go to the nice place, not the place where they're mean to you and they just kind of, shuffle you through as like a cattle call, right? But if you are on the hook for the full amount, then you're probably going to think much more. You'll be like, all right, fine, they're kind of jerks, but I'm going to save myself $5,000. So these are it's really fascinating, the range of costs for MRIs, for example, and MRI is a common example, but you can look this up for chest x-rays, you can look it up for a whole bunch of different things. So that I think is interesting. So private health insurance, so this is the quad model, right? We talked about financing, payment, insurance, and delivery. Well, the quad model kind of mixes together private insurance mixes together kind of payment and insurance. So why merge them? Well, it's a little bit different. So health insurance is a little bit different than say car insurance. Car insurance is based on an incident basis, whereas health insurance is over a period of time. So you get in a car accident, you hit a tree, right, or a hailstorm damages your house, you have a deductible, and then that you pay a certain amount up front, and then the insurance company kicks in. Under health insurance, you typically have a spend over a period of time. Let's go to those examples. We've talked about experience rating and community rating, so I'm going to leave that there. You can refer to it again. We've talked about, again, risk rating. Moral hazard, I briefly mentioned this, but the idea here is that when you're not paying the full cost of something, you're more likely to ask for more of it. If I have first dollar insurance, which means I don't pay any copay or co-insurance, I'm more likely to use the insurance than if I have to pay some copay. So if I pay nothing when I go to see my doctor, as opposed to having to pay, say, $50 when I go to see my doctor, I'm more likely to use the doctor more often, on average, if I have no copay than if I have to pay something. So that's moral hazard. And the difference here is, it's not that the doctor is working for free. Let's say the doctor is getting $150 per visit. Under zero copay for you, the doctor's still getting $150, but the insurance company is footing the bill, which means that the pool of people, because the insurance company doesn't actually pay anything, right? The insurance company collects money from all of us and then pays for the services that you use. So let's imagine that we're all paying into the insurance and we all have $0 or first dollar insurance, which means we pay nothing for our care, nothing out of pocket for our care. You, feeling like your care is free, go use it all the time. Well, that then causes the insurance company to say, wow, these people are using a lot of care, and they just raise the rates. And so everybody suffers because of this situation of moral hazard, where you're acting like it's free, but it's really dumping the cost on the rest of us. Adverse selection is a really interesting point as well. Let's imagine you are, and many of you are, healthy young people who have no health issues at all. Your primary risk is getting in a car accident. That is, in fact, the #1 killer of people your age, right? Is car accidents. So your main risk is that you'll get hurt from a car accident. So when you're presented with the fact that health insurance is going to cost you $500 a month at your first job, what you might say is, thanks so much, I'm not going to take it. I'm going to fly. I'm going to take my risks because I'm healthy and I don't think I'm going to get cancer. And the chance of me getting, even though the worst thing that will likely happen to me is a car accident, the chances are incredibly small that I'll actually get in a car accident, so on and so forth. So you might just choose not to get health insurance. The flip side is, what if you're an older, slightly obese person who doesn't maybe exercise very often, has a history of heart disease, has type 2 diabetes, which is the acquired diabetes from being obese and not exercising, because your pancreas starts to shut down because you eat too many cheeseburgers and too much ice cream. You're going to be spending a lot of money on healthcare because you need your insulin, you need to get regular checkups and so forth. So we have, on one hand, a person who knows they're healthy. On the other hand, a person who knows they have a lot of complex health issues. That person who has the complex health issues, which of these people is going to say, sign me up for the health insurance? The sick one, right? The one who knows they're going to use it. And then the healthy one's going to, be like $500 a month is a lot of money. So the problem, this is a problem of adverse selection. The people who are most likely to need the health insurance are the ones who are going to try the hardest to sign up for health insurance. The people who least need the health insurance are going to avoid paying for the health insurance. So adverse selection is a problem that health insurance companies face all the time, right? The people who are most eager to sign up are most likely the ones that the health insurance companies least want to insure, right? And the people who are avoiding signing up are probably the ones who they really want to sign up. So one of the ways that the ACA solved this was to make, to have what was called an individual mandate, which makes it you are legally required to get, under the original ACA, you are legally required to get health insurance. They initially called it, and there was a large penalty if you did not. The Supreme Court ruled that went to the Supreme Court, and under the American Constitution, you can't penalize somebody for not doing something, right? I can't put you in jail for not committing a crime. Like that's an absurdity, right? So that's the idea here. And so what the Supreme Court ruled was, Congress didn't really mean that it was a penalty. When they said penalty, what they really meant was it was a tax, which is a huge stretch of the imagination. But the Supreme Court, as much as they'd like to imagine they are above the political fray, are somewhat political, and so they're trying. So Justice Roberts kind of found a way to kind of squint at the words in the law and come up with the idea that this thing that was called a penalty by actual, like the words actually say penalty, was actually a tax. Well, the federal government can tax you all day long with there's no limit on what they can tax you for. So they can, while they can't penalize you for not doing something, they can tax you for not doing something. And so that's what the kind of loophole was that Justice Roberts drove through to keep the ACA in place. Now, you want that individual mandate because if the people who are healthy can opt out, that only leaves the unhealthy people in the pool. So you're young and you're healthy, we're going to get you to contribute $500 a month, and then there's going to be fat old me that's in that population right, that spends a lot more on healthcare than you do. And then there are people who are much less healthy than me who are also going to want to get in that pool with you. And so what happens? Well, you start, if left to your own devices, you'd get out of the pool, right? I don't want to be in the pool with all the old sick people. And so you'd get out of the pool and say, I'll just take my chances. Well, what happens if you get out of the pool? Well, now all that's left are so we were using you were subsidizing my care because you were spending less than 500, I was spending more than 500, right? So you were subsidizing my care. The excess that the insurance company got to keep because you are young and healthy was going to subsidize my care. You get out of the pool, you take your $500 and go home. Now the insurance company turns around and says, wow, we got a lot more spend per person here. We're going to have to raise the rates. Well, I'm not as sick as a lot of other people are. And they raised the rates enough. I'm getting out of the pool. And all that's left in the pool then are the really sick people, right? And then the insurance company has to raise the rates even more. And this is called the death spiral, insurance death spiral. It means that as the young, healthy people exit the pool, the cost of the premium keeps having to rise and rise because the per capita spend, the expected per capita spend keeps going up. So to stop the death spiral, that is why we had the individual mandate. Now, Trump set the tax to 0. So it used to be you'd pay a significant tax, aka penalty, if you didn't have health insurance under the ACA. Trump came in, set the penalty using executive orders, set the penalty to 0. Actually, let me correct that. I think it was actually part of the Trump tax plan. I forget what they called it. America Better tax plan or whatever. That set the penalty to 0. So now there is no tax or penalty, whatever you want to call it. But what we've seen is people are not getting out of the pool as fast as they thought. So we thought we'd have this huge problem with adverse selection. That's called the death spiral. So you should know that term because you'll hear insurance companies talk about it. All right. So you've got your next written assignment is to do a health plan analysis. So the next couple of minutes, I want to talk about different terms. And then if I have time, I'll show you a plan summary. So premium, we've been talking about, that's the money you pay per month, per year, whatever, to an insurer for a kind of plan. A deductible is a fixed amount of money under insurance. It's the amount you have to pay out of pocket before your health insurance kicks in and pays anything. So my health plan through Cigna, I believe is $500. I have a $500 deductible. So in any given year, before Cigna starts to pay any of my claims, I have to spend $500 out of pocket. Okay. After that, co-insurance kicks in. And there are some situations where co-payments are paid, and I'll show you a couple of exceptions. So co-payments and co-insurance are similar but different things. A co-payment is a fixed fee, like $25 to see your primary care provider, $35 for something else. I think my co-payment for going to the emergency room, if it is judged to be an actual emergency visit, is $100 flat fee. Even if it costs $10,000, I only have to pay $100. Co-insurance, on the other hand, is a percentage of the total cost. So, for example, if you go to see the doctor and co-insurance applies, and the doctor's bill is $100 and you have a 20% co-insurance rate, you will pay $20 and the insurance company will pay $80. Co-insurance usually kicks in after the deductible has been met in most cases. Co-payments sometimes apply before you meet the deductible, and I'll show you that in the UNH plan. So the difference between co-payment and co-insurance, they sound the same, but they're different. Co-payment, flat fee. Co-insurance, percentage. Just keep those in mind. an out-of-pocket maximum. So here we have an you have a deductible that is the minimum you have to spend before insurance starts paying anything. And it's usually a co-insurance rate that kicks in at that point. You pay out of pocket you pay out of pocket entirely until you hit your deductible. Then the insurance company kicks in and starts paying some portion of it, and you pay your co-insurance rate up to an out-of-pocket maximum. The out-of-pocket maximum is the maximum amount that you can spend out of pocket, hence the name, in the course of a year. That's usually a pretty big number, somewhere around like $5,000. And that out-of-pocket spend would be, say, your $500 deductible, and then all your co-insurance fees would add on there. So let's say you pay, it's $100 per visit to see a doctor. The first time, 5 times you go, you pay out of pocket 100%, $100 per visit, $500. That hits your deductible of $500. Now you hit 20% co-insurance after that $500 deductible. So each time after that, you spend $20 per doctor visit. So your total out-of-pocket spend on the 6th visit would be the $500 you spent, $100 per for the first 5, and then $20 for the 6th visit, because it's 20% co-insurance, right? So after the 6th visit, your total out-of-pocket spend would be $520. Does that make sense? You guys follow me? All right. So it will take you a while to get at $20 a visit. It'll take you a while to get to $5,000, right? But that would be, and then after you hit the out-of-pocket maximum, the insurance company pays 100%, except in some particular situations. Okay. We talk about network providers and out-of-network providers. Your insurance company typically contracts with a set of providers that agree to take a lower reimbursement rate in order to be part of the network. And the reason they take a lower reimbursement rate is because they believe the insurance company will drive business to them. So then that saves them the time of trying to market to other people. They're just the insurance company is just gonna provide them with customers. So that's a good news for them. And they're willing to take lower reimbursement because they don't have to spend money on marketing. So if I have to spend, $10 to get every patient in the door, I'm willing to take a $10 discount in order to get more people. Out of network, and so network providers, your typical insurance policy will distinguish between network providers and out of network providers, because out of network providers have not agreed to take a lower rate. And so that costs the insurance company more money, and they typically charge you more as well as a result. I've uploaded, let me just show you before we go. I've uploaded this is the UNH plan, and you can read through it at your leisure to get a sense of it. All right, I think we'll stop there because I'm out of time. And I'll have to spend I'll spend a little more time looking at this plan with you so you get ready to do the assignment. Have a good weekend. See you out there. Be safe.